Hi, welcome. We're so excited to have everyone here. We have our second installment of Heart Month, and I am so lucky to have all of you join myself and my two wonderful female colleagues here. So we are here tonight for a special episode of Heart Healthy with HonorHealth, a special geared just towards women. I'm joined by Dr. Christina Royce, who is a cardiologist here in our community and practices specifically just on females. And then I also have Chorney, who's a new nurse practitioner to join us, and also going to be working with just our female patients. So happy to have you guys here.
Thank you.
Yeah, it's exciting to have
to be here.
Female-only special. I think we've done so many different things geared around other things, and there's not a lot of females presence in this subspecialty anymore. So it's really nice to have that around. I think as we get started, we're going to kind of go and jump into some facts here and kind of educate our people watching and things like that. So I wanted to just go over a few statistics with you guys. So globally, we have a fact that says 275 million women are diagnosed with cardiovascular disease every year.
Yeah,
It's pretty substantial.
It definitely is. I mean, you know, when I think about whenever someone comes in to see me and I say, you know, what brings you in today? And I'm very pleasantly surprised that over the last 10 years, it's been a change in self-awareness, that women are starting to recognize that the number one cause of death in women is heart disease. And so I would say about 10 years ago, coming out of fellowship and sort of coming into the first 5 years of training, women were still very fearful about cancer as a cause of death, specifically stroke as a cause of death. But I think now they're starting to recognize that, you know, I probably do need to be aware of my cardiovascular risk and, you know, is this going to affect me? So I just think it's something that we...
It used to be a man's disease.
It is.
Classified as that. And I think that's super important to recognize that, you know, in the United States alone, 400,000 women will die of a cardiovascular related cause, whether it's heart disease, stroke, or other items related to that. And even more granular than that fact, 2,200 people die every day in the United States from cardiovascular disease, which is
staggering statistic.
Staggering, yeah.
It is.
It
really
is.
yeah.
And then I know, Dr. Royce, you touched on, you know, the number one killer for women. I think we were always taught, you're right, to look at cancer and breast cancer and all those things, but putting it into perspective that this does kill more women than all of those combined.
Absolutely.
So, and then this is even more interesting that in the United States, there was 457,000 total deaths in 2021 from COVID. And then in the United States for total deaths, there was 700,000 for cardiovascular disease.
We pulled that statistic for this presentation tonight to kind of be really up to date and to give people a sense of where we're at with women's health and the urgent concern.
I think we've had a rough couple of years. I think we're coming out of the other side, but I do think that is something that has made us focus a little bit more on what's going on with ourselves. And I always say you can't pour from an empty cup. And so we're all so busy as being moms and spouses and all those things and having jobs, and it's really, really difficult to manage it all. But if you don't manage yourself, it's really hard to manage everything else. So, so why don't we jump into our first topic? So when a patient asks you, Dr. Royce, do I have heart disease, or what is heart disease? What is your response to that?
Oh, I think that's such a good question. So, you know, when someone says, do I have heart disease? Because they'll come in and they'll say, you know, I'm looking to make sure I'm okay. And sometimes we'll find things like, for example, a coronary calcium score, or you'll get a CAT scan that makes a comment of atherosclerosis of the aorta. Or you'll maybe get an abdominal aorta ultrasound and it'll say abdominal aorta ectasia, funny big words. And so a lot of times now with electronic medical records being open for patients to read their own notes, they'll come in highlighting already, what is this? And they're like, well, what is this? I don't really want this. And you're like, okay, well, you know, you can't really argue with what's inside of you. I mean, we can look at it. So usually what I say to them is let's do a complete assessment, and then, but what is heart disease? So when we define the definition. So cardiovascular disease is really anything that affects the heart and vascular system. So it can be arterial disease of the arteries that feed the heart, or it could be officially carotid artery disease. It could be artery disease of the brain or intracranial disease, artery disease of the aorta or the legs, so peripheral artery disease, also known as PAD. But also, I actually think of cardiovascular disease as hypertension. And so, even though hypertension, the condition, having a high blood pressure condition, that actually is part of cardiovascular disease. And so, and we're going to get into a little later of what are the numbers, like what defines hypertension, but also at what point does hypertension start in life? Because, obesity epidemic really is a big problem for us. And so as our kids are younger and younger with obesity, the rates of hypertension start younger in life. And so I think that we are going to see that cardiovascular disease starts younger in life. So the first sort of point of engagement is when people say, like, do I have cardiovascular disease? Sometimes I have to say, well, let's figure out kind of the lay of the land. And if we can find something that they can pinpoint, that we can find, then I usually say, like, you actually do. But it's manageable, it's treatable, and all of these conditions, they are lifelong, they don't go away, so we have to tackle it.
Yeah. I think there's some really important things about people understanding do I have it? It really goes back to starting younger in life, knowing your numbers, knowing your risk factors, knowing those things that play into putting you at a higher risk for that. High blood hypertension is a big thing, and there's all kinds of things that feed into that. And we've all had, like we said, really stressful last 2 years. Yeah. And you notice more and more patients coming in now with hypertensive emergencies and things like that. But, in top of knowing your numbers, Mia, we talk about all the things that feed into understanding your numbers. One of the biggest things is also knowing your genetics.
100%.
And knowing your risk factors about that. Yeah. Why don't you give us a couple of, things that you can kind of talk about for epigenetics and then genetic testing in general?
Sure, I'd love to. Dr. Royce knows I'm very passionate about genetics, right?
This is Mia's favorite topic. Yeah.
So the beauty or the understanding of cardiovascular disease is there's not one specific gene that will contribute to cardiovascular disease. It's called polygenetic. So it means that many things play into us getting cardiovascular disease. And so you do want to be aware of your family history, making sure, we spend that time to look back 2-3 generations. But genetics does play into us getting cardiovascular disease, but also our environment is a huge factor. So we know from a lot of studies that epigenetics, that you referred to, that word means our environment. And how does our environment influence? So it's called resilience. So we may be given the predisposition genetically, perhaps our mother or our father has cardiovascular disease, but we really want our patients to focus on environment so our genes are resilient. So perhaps we can change that fork in the road to go a different direction. And we do have that capability.
That's, I think people underestimate the power of genetics. And so when looking at kind of your genetic predispositions to this, if a patient says to you, my age, right? And if your father had a heart attack before the age of 50, what does that do to your genetic predisposition or risk factors for that?
Yeah, so we look at that number 50. The number 50 is really important. If your mother or father has had a cardiovascular incident before the age of 50, your predisposition is higher. And so we're looking for that lead person who's had the condition. It's called the proban. And if you are a woman, as an example, let's talk about women. If you have a mother who's had cardiovascular event before the age of 50, it's a very large increase for a son for cardiovascular disease, so 7 to 11-fold increase.
Interesting.
Yeah, so we really want to make sure that we're very passionate at looking at family history.
Now, when we talk about genetics, it's not just really your risk factor pieces. There's a lot of other genetic components when caring for our patients. There's been a lot of research that's come out around, your genetic makeup and your genetic profile in terms of how they figured out there's certain markers that make you able to certain medications work better for you or things like that. Can you guys kind of talk a little bit about that piece?
Yeah, actually, I want to take one thing about cholesterol and genetics, just really quick, just to put it out there for a little pearl. Because we all have our little podcasts that we listen to, and the one that I can tolerate the quickest, just knowing my drive from my house to Thompson Peak campus, and then all the way down to Osborne, is actually, so the Journal of the American College of Cardiology puts out a nice podcast and of the editorial of the most sort of up-to-date article for the week that they find the most cutting edge. And this week's was actually on an article that came out looking at the marker lipoprotein little a. And so there are two markers that I love to check. And I actually check them because I only see women, patients. But I even before had been checking them in both patients. But I find it a fascinating marker that is the apolipoprotein A and apolipoprotein B levels, as well as lipoprotein little a. And those markers they're floating around our bloodstream, and they are a part of our cholesterol milieu that makes our cholesterol, that increases the risk of cholesterol sticking to our arteries. And so you can think of it as if you had an okay looking LDL, which is your bad cholesterol, but yet you had these other novel or new risk markers that are also floating around that we don't traditionally check for, because genetically you produce those at a higher level. That makes your LDL sticky. Because I always found it really fascinating that women had this sort of protective effect, that we didn't make cholesterol disease in our arteries till about 10 years, 15 years after men. And so what was it that was so protective about it? Or maybe the flip side was true. Men maybe didn't have something that was protective that made them have disease earlier. And so, the first thought was, oh, it's estrogen. But I think as we start to look at genetics more, we realize that it's not necessarily a gender issue, that it is genetics. And so, just in going back to your first question, which is, our genetics of what do we produce in terms of cholesterol, it's really wild, because we're so into knowing our numbers, which is super important. So we should know our total cholesterol, we should know our HDL or good cholesterol, we should know our LDL and bad cholesterol, you should know your blood pressure numbers, you should know your height and weight, you should know your body mass index, which all of that can be calculated. You can Google any of those calculators and figure that out online. But then when you see a cardiologist like us, we calculate how do we add in what are these extra markers. And so I'm going to let Mia take the part about how do medications and how do our genetics of how we metabolize drugs factor in, because that's a really cool field. Because once we identify you do need treatment, that's medication treatment, women, I do find, have a little bit more side effects. And traditionally, what I've heard is that women feel that they see other providers and they come to me saying, I'm frustrated because this other person didn't listen to what I was going through, and they said, well, try this drug and try that drug, and I don't know what to do with you. And I just feel that, having the privilege to take care of someone, I don't really want to ever dismiss someone's concerns. And so I just really find that listening to what is bothering a female patient, and if it's that they feel dismissed, then you know what, sometimes you need to spend a few more minutes with them. And if it's because they're having a side effect, then I really think listening to what is it about their genetic makeup that they can't metabolize a drug. And so, yeah, Mia, take it away if you know
pressure's
anything.
on.
I know.
We're all ears.
And I'll jump in, but
So the reason you're bringing it up is we know that a lot of the studies of medicine in women is understudied in women. So that's a big issue. So we're finding a lot of the trials or the medication trials are very way towards men. And so we really aren't accurate or know for sure how women are responding to medication. So genetics has helped us a little bit with that. And right now, as Christina was talking about, Dr. Royce, the panel, the ApoB and stuff, we can test that now in genetics. So we can look to see, is someone not the right metabolizer, that PCSK9s, and it's really guiding our practice to give a little bit more accuracy. So it's really
so
it's
fascinating.
been amazing. It is
yeah,
fascinating.
It's really, really incredible. I think it's so important. We'll talk about more in a little bit about more of our work at HonorHealth for women care. But as we kind of continue into some of our other topics, so one of the other ones that we wanted to talk about, something near and dear to me, is conditions that are unique to women, starting with kind of pregnancy, stress in pregnancy, and all those things that happen to you. It's important to talk about. I think it's something that we as young women, I'm a mom of 2 crazy little kids who I think are watching right now, but that are 4 and 6 now. And going through pregnancy was rough for me. I wasn't one of the lucky ones that got to just have a great, glowing pregnancy. And I had some very real issues that were bubbling up with cardiovascular. And working here for a long time, I have a lot of great connections, but a lot of the response that I got initially was, Lindsay, you're just having anxiety from being pregnant. And finally finding someone that listened to me as a female was super important in finding care. So I'm really happy that you've shifted your practice now. I wish you were doing that sooner, but like 6 years ago. But now, let's talk about pregnancy in women and why it's important to kind of talk about this, that a lot of things do tend to bubble up during pregnancy.
Yeah. So the whole field of cardio obstetrics is, it's a really exciting world out there. So I think the idea that you can take 2 completely different fields of medicine and still have a really cool career path is it's really neat. So an area that I focus at least a third of my week or work week on is on the patient who is either contemplating pregnancy or currently pregnant or recently pregnant. And because pregnant patients have a huge amount of cardiovascular demands on their body. So just as anyone listening who is completely baffled why we as a cardiac presentation are even going to talk about pregnancy, I'm just going to really quick plug pregnancy. So what happens when you're pregnant is you are growing at any one point in time an entirely new body inside of you. So that the workload that your body has to do is you have to increase your own body's output to the uterus, right? You have to put a lot of output to an organ that normally doesn't demand that much output. So in order to do that, you have to increase your body's red blood cell mass, you have to increase your heart rate, you have to dilate arteries in different ways, no longer to your own vital organs to the same priority. And then you have to get rid of a lot of the heat you're producing from the hormones. So you're going to dilate the surface arteries. And you have to do that in a way that doesn't mess up your own body's natural daily functions. So women, as young kids with congenital heart disease are getting older and growing into a mature womanhood, they're deciding to get pregnant. So as the technology in helping pediatric children grow up and become childbearing adults advances, now they become young enough to now have kids. And now also women who postpone having children until later or who have infertility issues who then cannot get pregnant and then have multiple births. So all of these women who decide they're going to get pregnant at some point now have a higher workload on their heart, right? So those women do need they need a team. And so this multidisciplinary team approach is best served with your obstetrician, with a cardiologist that is comfortable in dealing with pregnant women, who has enough understanding of what's normal and what's not normal, and who has an office staff and a team that understands like how quickly you need to get patients in, and who also just understands what pregnancy is about. It's a 40-week process, but after 30 weeks, it's kind of fair game, right?
Yeah.
So I think the arrhythmias and these tachycardias that can happen can be really profound, and they can happen at sometimes at a rate that is so unexpected that you have to be able to say, that's not normal and we need to get you to the hospital. So I was really excited that at Shea campus, when it was decided to open their labor and delivery ward with cardiac monitoring beds, and that was just amazing. And so those labor and delivery nurses became much more comfortable looking at EKG strips and just talking. I mean, to be able to understand what it meant to be able to talk me through, well, what do you see on the monitor and how do you put a telemetry pack on a patient? That was phenomenal. So, sorry, I digress because I get very passionate about this. But what I can tell you is the field of cardioobstetrics can keep you busy every day because every day is a new concept. You can have, my days can be a valvular heart disease patient who now wants to have kids, so we have to figure out a way to get her off blood thinners to safely deliver a baby without hemorrhaging. So I think the first question was what? I don't remember. It's just
I think
super exciting.
There's so many different things I think that can happen when you are pregnant, and I think a lot of times people go through life, not being a congenital heart patient, right? They live their life perfectly normal, and then they're pregnant, and you get to about that 12, 14, 16-week mark where your blood volume doubles overnight, and all of a sudden you start having arrhythmia or you're fainting or things like that. And it's really scary. You're pregnant and you're like, everything's changing and you have this belly growing and then you have this baby growing inside of you and now you're passing out and you're like, oh my God, how am I gonna make it to the end? This is only the beginning. So at least that's how I felt. So I think that it's really important for people to know that, we have done a lot of work at HonorHealth and we are really making some big strides in our community to provide a service to women, not just women who are seeking preventative care, who need cardiovascular care, but also, the important field of cardiobstetrics and them to be able to understand, we're here, we're ready to take care of you, and we want to take care of you. So and we're ready to listen to you too.
Oh, absolutely. So, I know. I get excited about it, but mostly I do sit kind of quiet in the room. I will say that the one thing in pregnancy that is the most interesting to me, in terms of who the patients are that I'm most intrigued by, is because it's a long-term relationship at that point, is the woman who is recognized to have high blood pressure in pregnancy, and the woman who is recognized to have some gestational diabetes. Because I often think, and I'll ask even like my 85-year-old patients, like, do you remember, did you have toxemia pregnancy or high blood pressure? And they're like, that was so long ago, but I did. And that helps me understand, because if you have preeclampsia, if you have hypertension or gestational hypertension, you are at risk later in life, far higher to get hypertension. And so that is the person who I should be seeing postpartum. And as a matter of fact, that's the person who the obstetrician is now recognizing, that's somebody who needs to be seeing a cardiologist. Oftentimes, these women, they're done delivering a baby, they're so busy with appointments, the newborns, and they're excited to have their new family that the women forget about themselves. And then they wonder, gosh, I'm so tired and I have these throbbing headaches and I don't understand, I can't lose my weight and I don't know what's wrong with me. And you find out that it's untreated hypertension. They're in these very bad cycles and they can be like that for years, 3-4 years before they even recognize it. And on top of that, every time you go to the doctor, those little high blood pressures can be ignored, right? You'll say, well, it's 142/82. It's because I was tired.
I have white coat syndrome.
I have white coat syndrome where I just drank a coffee before I came in. And so, it gets played off a lot because we're afraid to say, like, is that a problem? Is that okay? I mean, what is high blood pressure? I don't even know, right? And so you have to kind of keep educating. And the obstetricians are doing an incredible job saying, these are high, this is not normal. I don't want to scare you, but I'm going to have you see a cardiologist just to start talking to them and have you understand that we got to keep an eye on it.
Yeah, I think
I
that's
love your expression you always say to patients. You probably don't even realize you say it, but it's so perfect. Is being pregnant is like its own inherent stress test.
It really is.
Right? It's like you're having a stress test. And it's a great statement.
Yeah.
Pulling that all together.
I think that's an excellent one. And then you get another stress test when the baby comes and you're not
There
sleeping.
you go, right?
And all those things. And so I think that those are all, really, really great indicators. Mia, you touched a little bit ago on the clinical trial aspect. This is something I briefly knew from my time being clinical, and now moving into more service line oriented work and programmatic development. I get, a little bit more removed from some of the clinical pieces. And now being involved in working with the American Heart Association and their Inspire Red campaign, I was baffled at some of these statistics that they gave us. Two that actually stood out. The first one not having to do with actual trials, but was the life expectancy differentiator between a woman living in Phoenix and a woman living in North Scottsdale, of it being 14 years less for the woman in Phoenix versus Scottsdale. So that is astounding to me, if you think about 14 years. So that's a number one thing. And the second thing was their information on clinical trials. And I don't think that we realize this even working in healthcare and really understanding the impact of what this does and how much it affects along the road. But when we talk about those trials, women make up 25 to 38% of all
It's very low.
people enrolled in those trials. And these are huge trials that are deciding new drugs, new devices, and all those things. So how do you think we can kind of encourage more women to enroll and really take, I think some people think of like the guinea pig analogy of things, of how can we really educate our community to be more involved in those things and to understand where they want to get involved and how it can help them and benefit their health.
I agree. We want to eliminate that disparity of care. 100%. Options like this, we're getting that word out to people. If you got an opportunity to be in a trial or just awareness, really consider it. But the stats are extremely low in female trials or devices. And so I applaud HonorHealth for having a women's driven program. We're recognizing that passion, that need to really focus on that action. And I don't know what else to add about that, but you summed it up. It's exactly what's going on. That's why we're doing this program. Is we're trying to make sure we're putting that passion and that attention on there.
I would say that, the hard part about enrolling female patients is I think women are, we're discriminate with where we put our time, our attention, where we put our health and where we invest ourselves. And I think that when a trial is designed, if it's designed by a female, and I'm going to throw it out there because there are very successful trials, and for, probably some of our largest, including like a women's ischemia trial. So those trials that look at women, they spend heavily on the education part to really get nurse educators to say, well, let me just sit down with you and explain everything, answer every question, have you come back, and we'll do it again. And so most of our successful programs, like even in our structural heart program, are because we have a nurse navigator that then can navigate and literally say, okay, I'm going to meet with you, we're going to talk about this, and then I'm going to talk about it again with you, and I'm going to talk about it again with you. And so I think that's how my patients who are discriminant women, that's how they think. I'm not saying that's not how the men think, but I just know that that's how my female patients think. And so knowing that that's a barrier, I think that when we open our doors for our discrete women's clinic and we want to do trials, I think I'm going to have to really think about, it's all informational, and also to understand, like, it's not a guinea pig thing where we want to experiment on you, but it's really, like, some of the trials are just informational. Let's figure out.
I was just going to say, that's the thing.
Find out what happens to you. Let me follow you over time, but that's still good information.
It is.
I think it goes back to, you see those memes and things on the internet about why women live longer than men. We're just more cautious with things. I think we're not jumping off of a roof into a pool or something. So I think we're just much more cautious about making a decision like that. And I think in general, if it's not explained extremely thoroughly to people, especially females, we're not doing it. If I don't know exactly what you're telling me to do, there's no chance that I'm going to do that.
Yeah.
So I think that's something super important to, as we kind of venture into, you know, some of the things in the future that, you know, we want to make sure that women have a ability and understanding to enroll in some of those trials. So some of the other things I wanted to talk about with you guys tonight were, we talked about clinical trials, and Mia, you know, you touched a little bit briefly on that disparity of care. So going into that topic, you know, having ways that we can kind of decrease that piece of things. How can we reduce that disparity of care between women? I mean, when we look at things like, there are statistics that talk about because women present differently than men when they're having a heart attack, that they will oftentimes wait up to 3 hours longer for that little stent in their heart to save their life than a man would. You know, and Christina, you can touch on some of those, like symptom presentation. That's probably a great place to start.
Now typical. We finally got recognition that it's not atypical. It's our symptom as a woman.
We do have different symptoms. We do. And so when a female has a heart attack, why don't you talk a little bit about those things and why it looks so different?
Yeah. So actually, I'm going to talk directly into the camera because I just want everyone to hear this. All right. So the general sort of teaching in the 40s was this is a heart attack. So it's grabbing your chest and it feels like this. So the problem is we always say is it chest pain. But I can tell you that the nerves that innervate the heart, those nerve fibers, they will run anywhere from this area of the jaw, so earlobe, jaw, to about the wrist, and then to probably about the sort of lower portion of the like gallbladder and spleen area, both sides, and then even towards the back. So the hard part when you go into the emergency room as a female is if you say, I just don't feel right, you have to add more detail, right, women? So you have to add more detail. So you can say, I feel funny in this area, but the symptoms that generally you can describe, and actually many women describe in a heart attack, are I feel pulling in my arm, or I feel like my teeth are uncomfortable. I feel like my jaw is uncomfortable, and oftentimes it's with any exertion. So that means that there's a plaque in the heart that is unstable. So that every time you push your heart to do something, it can't deliver more blood to the muscle, and your heart is hurting. A typical another symptom would be every time I walk and do an errand, if I walk down to the mailbox and back, I have problems like heartburn, belching, spasm in my back. You know, yes, I realize all of us have aches and pains. So if you know you slipped a disc and it hurts there and you're working on it with injections, that's probably not it. But if it's a new and unusual symptom, that's profound fatigue, that could be the symptom of angina, and that's what that is. So heart attacks that happen while you're at rest would be a plaque that is ruptured off, and that is causing, so the plaque that ruptures off, when the artery closes down, because your body puts platelets in that little plaque where it ruptures off, it puts platelets to heal that area, and now the muscle has no blood flow, so the muscle is telling you, I hurt right now, and it's going to give you a lot of symptoms. It's not going to be kind of subtle. It's going to be very uncomfortable and persistent. So don't wait for hours. You take your aspirin and you immediately call 911, or if you live right next to the hospital, you can walk or drive. But you can't drive yourself.
You don't drive, yeah.
Yeah, you get somebody to drive you. But for the most part, that's what you call 911 for. This is what they do. They have a fast track right into the hospital emergency room, and you'll immediately bypass everyone who's waiting, because it's really important. So for us, time is muscle. And it's better to go into the hospital and be told you're not having a heart attack than it is to be told you had a heart attack and we lost a lot of muscle, and so now your heart muscle's weak. Congratulations, you need a defibrillator. So I can just tell you that's
more than you think.
Yeah, it happens often. So I think anything from chin to probably right above your belly button.
And I liked your comment about fatigue, because a lot of women do complain of fatigue or shortness of breath or those things. And it has been recognized now by the American Heart Association and American Cardiology that it is a symptom.
Yeah.
It is now a typical symptom. So I was glad that you talked about that. That's
The
amazing.
biggest thing that we've seen is women will just say, oh, I took some aspirin and I went back to bed.
Yeah.
It's like, please, please, please don't go back to bed.
Don't go back.
Yeah.
Call 911 and go to the hospital. So I think that that's just really important to talk about. And I liked how you showed them, where to look at, because I think women, we have to be our own advocate in this, and you have to be able to communicate what's going on with you. Why don't we talk a little bit about the lifestyle risk factor modification?
Oh, yeah.
I know I couldn't use your favorite graphic tonight, but there's a graphic that is circulating the internet. It's from the American Heart Association, and it's called the Simple 7 Lifestyle Risk Modification. Lifestyle risk factor modification.
Yeah.
So it covers 7 little areas of things that you should be focusing on. So why don't you guys each take a couple of them and talk about them.
definitely. Oh, do you want to start off?
Okay. How about I'll talk about activity?
I know, it's your favorite.
I love it. I'm very passionate about everybody moving their bodies. So just want to encourage everyone to, as women, get out there, move your body. Perhaps that's yoga for you, maybe that's resistance at home, or whatever will work. The recommendation is 150 minutes a week for us to move our body, to be active. So perhaps that's an hour one day, 15 minutes the next. But for everyone, that's not achievable. So we would just love you, get out there, move your body, something that elevates your heart rate for a little bit. I often get people say, I have a really stressful job. I stand all day, and I'm walking up and down the hallways, but the problem with that is your heart rate goes up and then it comes down again right away as soon as we stop. So we would encourage you, maybe on your coffee break or your lunch break, get out for a brisk walk, but try to move your body so your heart rate comes up consistently for 20 minutes and then is able to come back down. So your goal for every one of you is 150 minutes a week.
Yes. I'm going to tackle no smoking, the biggest lifestyle modification you can do. I've heard every excuse, but I'm a tough one. I think your biggest excuse is you got to do it. There is no excuse. It is a habit, and our brains, I really, really believe our brains have the ability to work towards new habits. So the risk factor modification is you must quit smoking. We know that even if you're 90 years old and quit tobacco, you will gain life, you will gain days alive. And you know what? That makes a difference for people. So the point of that is you are not too old to quit, and you have to watch out because younger and younger kids are starting to smoke. The other issues are patients will ask me, well, what about nicotine replacement? I do not advocate that everyone should go out and start nicotine replacement, but I think it's a great bridge to come off nicotine replacement and then eventually be off. So that's a great tool, but nicotine is probably, and smoking has been one of the most harmful heart health in terms of how do we accelerate our heart disease. So I'm a proponent of no smoking.
So those are a couple. So some of the other ones are, eating right, so diet. There's cholesterol control, which you touched on earlier. Reducing your blood sugar. We talked about losing weight, so not just getting moving, but losing weight. And managing your blood pressure. That's a really good one as well. So I think things that may not be particularly included in this are talking about sleep. And you've actually done a really good talk on sleep and how it affects you. And I think the biggest thing that I've learned over the last few months is when we talk about sleep, it's accumulative. It's not like, oh well, it's fine. I slept. I got 6 hours today, and then tonight I only get 4. Well, you're still missing 5 hours of sleep in there. So I think everyone understanding of really what that how much sleep do they need as a female in life, and then what are the impact of not sleeping on your health?
Oh yeah, I'll give you a tidbit really quick, because I think sleep in females is super fascinating. So, we have all sort of heard or seen these graphics from our pediatricians, like kids sleep a little bit, longer, and then they shorten their sleep cycles, and then we know that our teenagers hardly sleep, although they should be. And then there's a smattering, and then we'll hear from our older patients who say, well, I go to sleep at 2 a.m. and I've got nothing to do, I'm retired, so I wake up whenever. And the reality is we need sleep. Our brains need to go through a proper sleep cycle. It actually has to do not just so much with cleaning up, memory and downloading thoughts, but it also has to do with the very important biologic activities that happen during our sleep. So even sleeping with lights on or sleeping with noise on is actually not sleep. So 7.5 hours is really truly the magic number. And that's probably the magic number throughout our adult lives as women. But postmenopausally, there is a difference in sleep patterns, and we start to change our amount of time in restorative sleep cycles. And so that leads to daytime fatigue the next day. And the problem is when you don't go through proper sleep cycles, it leads to obesity. And so, the reason why that's important is to understand is because when you're not sleeping and you're sleeping later, for example, you start to do two things. One is you eat and snack because it's part of this hormonal balance that happens, which adds calories to your day. But you also throw off your cortisol levels. And so, you get into these really pathologic behaviors. So I do have women that tell me that they sit in bed and they're insomniacs. And there are sleep specialists, that can kind of work with what part of the sleep cycle are you having trouble with. And I think you're absolutely right. Sleep debt or sleep deprivation, you can't always make that up. So I think we have to prioritize sleep. So you have to prioritize it just like we prioritize waking up. So I think of going to sleep should be just like setting an alarm to go to sleep. Like it just has to be so. You have to say, okay, at 8:30 my little alarm goes off to say, all right, it's 8:30, I've got to start wrapping it up. Making sure I do my evening chores or getting ready for the night. And then there has to be an end time that you're in bed, lights off, blue lights, like all the little charger lights off, and no more noises, no TV background noises, preferably if you get a sleep mask or at least in a very dark room. And, you do notice the changes. And so it's, I find sleep to be such a priority that if I don't sleep the right amount of time, I'm not actually functioning well the next day.
Yeah, definitely. I think there's a lot of tools out now too for people. There's like the apps, like the Calm app that does.
Awesome.
I listened to a really good one last night. I slept really good last night about like deep sleep hypnosis. And I think that I was very skeptical of those things, but they do work, I think. So
I own a mask.
Yeah.
They're great.
It's interesting. So back to a couple other things. We've had a really great kind of discussion tonight about some things, but I want to get to a topic that's very important to, I think, all of us up here and some others here at HonorHealth, and kind of where we're heading over the next month or so within our cardiovascular services. So we, obviously have recognized that within our community, we want to do something unique. We want to be able to offer something to women that's very unique for the community. So with that being said, we have been doing a lot of work internally with all of us, but I think we can announce the cat out of the bag now and talk about our women's clinic that we're opening up. So I'm thrilled to now talk about this now with everyone, and we've slightly been mentioning it here and there, but we are opening up a women's cardiovascular heart health center at our Shea Medical Center, and our first clinic day is going to be with Mia on March 30th, and then Dr. Royce on the 31st. I think maybe can you guys just talk a little bit about both of you? Maybe start Mia with you about why you want to do this and why you're what your goal is out of this clinic.
Okay, that's a big question, girl. I could talk all night on that.
You have a few minutes.
I'm very passionate, as you know, about women's health. I've been a cardiac patient in my past, as we've shared. So again, it lends to that having time for the patient, being able to really listen, and hopefully, to be honest, to really make a difference in the impact of cardiovascular disease for our local area. And honestly, Lindsay, I don't know what to say. I could talk forever.
Yeah.
It just means so much to have this opportunity to make an impact. So, you know, we're hoping to have that time for you to really make sure we're doing those comprehensive histories, paying attention to the details, exactly, and really kind of giving that extra special service as well as some teaching, right? Some prevention and teaching and really giving that focus, addressing the simple 7.
Yeah.
Having that time.
Yeah. I think, and Dr. Royce, you know, you've been doing this in private practice now for the last few years of really transitioning and dedicating your time solely to that. So we're really excited to kind of have you coming on board with us and, you know, doing that within the health center now. So
yeah, it's going to be exciting. So first of all, I'm super excited that HonorHealth is on board with creating the Women's Heart Health Center. So we are going to be in the lobby at HonorHealth Shea, which is going to be super easy to find. So you walk in at the volunteer desk and over to the right, right in front of you. Cannot miss it.
Next to the spa.
Next to the spa. So if anyone gets lost, that's where we are. Just kidding. We'll be slaving it out. But actually, you know, the reason why we wanted to be there is for 2 reasons. First of all, the women who already see the labor and delivery department, they walk in, they go upstairs to the 2nd floor. So it's a very easy transition for a woman who's going for their obstetrics visit. They can also see me at the cardio B visit there. The second thing is we want to be visible. We don't want to be hidden in the corner. We want to be front and center. We want to help represent and not only elevate and by being front and center and enhancing the knowledge and making sure that everyone understands that we are here to educate everyone that cardiovascular disease is not only the #1 killer of women, but we are here to make a difference. So Mia's office visits will include all the standard things that you expect. It's going to be an EKG. You'll have your standard discussion about family pedigree, family risk factors. We can go through symptoms approach. We can talk about everything that's personalized that we need to do to get that, to get you assessed. We'll get your cardiovascular stress testing, risk stratification, and then a revisit. But what we're adding to it, which is the exciting part, is mindfulness discussions, the opportunity for genetics, and you know, those are the things that I think go above and beyond. So our research and where we really want to be is to the point that phase 2 and beyond will be that we start to organize the registries that exist. So many women who have problems, and when you start to coalesce the common problems, spontaneous coronary artery dissection, these are conditions that happen in women, and you start to collect and you start to have a place where women can collect and find commonality. And so we want to serve as a place of respite, and so that when we have enough of a mass of women with common problems, now we can start to make a difference. So we're excited. So we are definitely in the lobby, and in end of March, we'll be present, and people can stop by and say hello with masks on. And
I think the other thing too that we didn't quite touch on, I think that one of the major goals of this is really providing the whole spectrum of care. I think females are really, we're a double-edged sword, right? We're really complex, but that's what makes us unique. And providing care for the whole spectrum of women. I mean, there's so many things that can contribute to your cardiovascular care that's not just the anatomy of your heart or your genetics or you developing heart disease. We tend to try to pour from an empty cup over and over and over again and expect a different result. So I think that's another thing that we really want to focus on is really, providing that whole spectrum of care and making sure that women are addressing all those things that can contribute to their health issues going on. So I think, so we're really excited about that. I think we have a couple of questions that came through today from people. So one of the questions, we'll start with the first part of it. So what age should a female, start seeing a cardiologist?
We were having that discussion, weren't we? Because it's so variable.
This is really hard because
it's a variable question.
I am 36 years old and I've seen a cardiologist several times. So.
Well, I think it's any female who's had a complication in pregnancy absolutely should be seeing a cardiologist. So for me, the high-risk pregnancy indicators would be, so if you're a woman or if you have a daughter or a sister who's had a pregnancy that had a delivery before 37 weeks, who has had multiple miscarriages, who has had preeclampsia, who has had intrauterine growth restrictions, so those are big ones. Gestational hypertension, gestational diabetes. You should be seeing a cardiologist. Also, someone
family
with
history,
strong family history,
first degree relative. Hey.
So and absolutely first degree relative. So if you have a sister or brother with a heart attack, and we'll take any age, but like just for sort of in your mind, think anything around the age of 50 or younger. But listen, heart attacks happen at all ages. We've seen them at age 19, and we've seen them starting as young as age 35 in families. So anyone with a family history of premature coronary disease should be seeing a cardiologist, especially in a woman. Another person that should be seeing a cardiologist, another woman that should be seeing a cardiologist, thank you, is a woman who has had breast cancer, who has had chemotherapy, radiation, and certain chemotherapy agents can affect the heart, and those patients should be referred to a cardiologist. And we haven't touched on that topic, but that's important. And so as we develop this comprehensive care for a woman, that's why we feel so passionate about it, because these are areas that are generally missed and not addressed. And so we will continue to roll out our programs and make visible what we have to offer and who should be seeing us. But it's because we will continue to follow. But those can have complications on the heart. And then hypertension, anyone with a blood pressure greater than 130/80 at any age should at least have a once over by a cardiologist, make sure we're not missing things.
What about autoimmune disorders? Women with autoimmune disease.
Yes, fire away.
So women do have a higher tendency of autoimmune, so that could be lupus or, psoriatic arthritis, those sort of things. It causes irritation in our body, like an inflammatory. And so we do know that that can lend to microvascular changes for a woman. So yeah, absolutely, that's really important. Yep.
And then what about, so when a patient comes in for the first time and they, have some genetic risk factors in terms of, close relative, what can they expect from testing to be, like, what are you guys gonna make them do?
Oh yeah, make them do.
Yeah, that's always the question that they say, what are you going to make me do? And I'm like, what do you want to do?
I think, first of all, I always talk to people. I think you have to have a very practical approach to things. There are some absolutes that are tools that we need. I need an EKG. I need that because that is, for me, a vital sign. I need to know what's going on electrically on your heart. So if I don't have an EKG, it just really hampers me. For me, it just helps me understand if there's already scar tissue. So we're going to put a couple stickers on your chest and just look at an EKG. But I'm a non-invasive doc, so I really want to see an echocardiogram. I need to see an ultrasound of your heart. That's the easiest way for me to visualize the heart function. So I'd love an echocardiogram. And then on my wish list would be a form of a stress test. And then if you gave me carte blanche, I'd probably do like 1 or 2 more blood tests and maybe even a CAT scan or 2. But we have to talk about everything because it's really important, first of all, again, as a female, I think we have to talk about time, cost, convenience, and yes, those are all important because that is exactly what is the biggest barrier sometimes for women to get care. And so by coming, and again, I do this in the office now. So I try to schedule appointments. I always tell them, you can bring your kids. Like, I don't want you to feel so stressed out that you can't get care. So we're going to try to work with you and we're going to try to make it convenient. But I have told women, like, these are absolute musts. You have to get this done. And I think people hear it. You know, women hear it, but we have to explain why.
And telehealth. I mean, we'll accommodate you.
Yeah.
Telehealth, we got a bassinet coming for the Women's
I think
Center.
that is one thing that, one really positive thing that came out of COVID, right? The only thing, but was, just really everyone's created some really robust platforms for telemedicine, and I think it's
incredible.
made the access to care so much easier for people. Just your phone and everything's done and no big deal. So I think that's one big thing. We talked about the autoimmune thing. Some other questions, we talked about testing. What about for a person who said, I had a heart attack 5 years ago, I'm fine now? What do you tell them?
Well, yeah, like it's gone away, and I'm living in a place where I'm imagining that this never happened. Yeah, well, so this is where we are going to be having a counselor on staff. Like our women need a little more loving care. So, and why do I say that? Because when you have heart disease, it doesn't go away. When you have a chronic medical condition and you have to live with it, there's an emotional impact that creates some real trauma in your brain, and that prevents us from having a good relationship. And sometimes that relationship is you hide from the doctor, and sometimes that relationship is you don't like that doctor, and sometimes that relationship is I'm not going to take my pills and I will never see you again. And that's not the right relationship to have with a woman. The relationship is best, let's get you to a place where you're not fearful and you understand what's going on so that you're empowered to take care of yourself. So I do have those people who are like, oh no, I had a heart attack and the surgeon said they fixed it and they said I was fine. And I'm like, no. We have got to get you on things to keep you fine because what was fixed is all just to keep it stable, but now we have to take care of it. And so it's all education.
Yeah.
And so
I think that's really important too. And I think understanding too, you have patients that get, they get a heart stent put in because they come in, they have a heart attack and they're like, oh no, he fixed it. Like I don't need to do anything else. But understanding that, guess what? If you continue on that same path, that stent
goes back
can
to the
get
simple seven. We got to go back.
reclosed again. Yeah. So I think that's really important. And I think, it's been a fun time to talk about all this, and I think it's getting us all really excited for what's to come in the next month or so here at HonorHealth, and I'm really grateful to have you guys along for the ride.
Thanks so much for having us.
Do this all, and really just be able to kind of educate our community more. So it's been fun, and I'm looking forward to more of these. With that being said, we're closing in on the end of our hour, and we are going to go ahead and sign off for the night, I think, at this point. So thank you so much for joining us, and we look forward to seeing you guys in our heart clinic at Shea.